Good afternoon, ladies and gentlemen. It's my pleasure to be here to share our experience on COVID-19 treatment and management in China. So I'm Dr. Wang from Peking University First Hospital. So as Dr. Gao has introduced that we experienced a very severe epidemic of COVID-19 in China, especially in Hubei and Wuhan. So over 80,000 people ill, and over 3,000 people passed away. So although we have so many patients, so we know very little about the disease. So I want to skip the two slides. So first, I would like to talk about the pathology change of COVID-19. So right now, only a few papers published dealing with the change of COVID-19. This is a report published recently, so only two cases. These two cases are lung cancer patient and accept lobectomy. So and later COVID-19 was discovered. So the doctor retrospective analysis the lung tissue close to the cancer. So it shows the early change of COVID-19. So I think also only two cases. So this paper is very important to give us very important information about early change of COVID-19. So the lung shows edema, proteinaceous exudates, focal reactive hyperplasia of pneumocytes with patchy inflammatory cellular infiltration. And also hyaline membranes was not prominent. So that is quite different from late change of COVID-19 in the lung. Here is the pathology from autopsies of COVID-19 patients. So from several passed away patients. So first, bilateral hyaline membrane formation is observed. So it is a hallmark of diffuse alveolar damage. Also, cellular fibromyxoid exudates and discrimination of pneumocytes and pulmonary edema is revealed. Interstitial mononuclear inflammation infiltrates, so it is dominated by lymphocytes. Bronchial epithelial cell shedding is observed, and the mucous mucus plugging are formed. So that may be contribute to some airway obstruction to the late phase of COVID-19. Another very important finding is that the COVID-19 virus can attack immunity system. So from autopsy examination, so the atrophy of spleen and the reduced lymphocyte count, both spleen and the lymph nodes, are observed. So here is the epidemiological features. The source of infection, as mentioned by Dr. Gao, had mentioned, the patient, COVID-19 patient is the main source, and some symptomatic patient. So although no symptom, but the virus is positive, and potentially some animals may be infected with the virus and can be the source of infection. So the transmission is mainly through respiratory droplets and close contact. Aerosol spread in a relatively closed environment for long time exposure to high concentration of aerosols may be a way of transmission. So although it is rare, but there should be some transmission caused by this way. So the susceptibility of the virus, so everyone is susceptible, so nobody can avoid infection. The mean incubation period is 5 to 6 days, ranging from 1 to 14 days. So healthcare workers' infection is a very hot topic and very paid attention by the public and also by the government. So as February the 20th, 2020, there were over 2,000 COVID-19 confirmed cases reported among healthcare workers from over 400 hospitals across China. But most of them, over 80% are reported from Hubei. So that may be due to the quick spreading of the virus in Hubei, especially in Wuhan, and the hospitals are very in a very hurry to confronting the epidemic. So the preparation is not enough. There is some problems with the material preparation and also the technological preparation. So only a few cases are from other areas out of Hubei. So some risk factors are considered relates to healthcare workers' infection. So first, I think it is the no readiness or preparedness to COVID-19 in the hospital. So there is no track, there is no alert to the disease. So and also the awareness or recognition of the disease, so is very important factor for those, especially in other department except respiratory department or infectious disease department. So at the very beginning, especially in Wuhan, so we experienced some shortage of protection equipment like PPE. So the lacking of PPE can arouse some problem, so can contribute to the cross-infection of health workers. And so during my observation, so I noted that some fever clinic, so the fever clinic is coming from SARS times. So after SARS, as for the identifying the comeback of SARS, so almost all the hospital established a fever clinic. So if a patient have fever, so he or she was tracked to the fever clinic. So, but the fever clinic is not a standardized building. So some use very small rooms, so isolated from the main building. So all the ventilation is poor. So in this area, so although you have full protection with PPE, so it has the possibility to be infected, especially for health workers. So here is the definition adopted widely in China. So for suspected cases, we emphasized the epidemiological history. The patient will have a history of contact with COVID-19 patients, and all the patient had been to Wuhan or its surrounding areas. This is the past, but right now we should pay more attention to the areas from overseas. And also, the patient may not have a confirmed case, but have contact with a patient with fever or respiratory symptoms from areas with COVID-19. At last, the patient belongs to one of them, the member of a cluster of cases. So this is the epidemiological history. So the clinical manifestation is similar to most of the pneumonia, fever and all respiratory symptoms. The chest X-ray has infiltration mostly bilaterally, but if you observe from the very beginning to the late phase, you can recognize the COVID-19 has its own characteristics. And white blood cells is normal or decreased, and also a decreased lymphocytes is very important predictor for the patient severity. A suspected case has any of the epidemiological history plus any two clinical manifestation of all the three clinical manifestations if there is no clear epidemiological history. The confirmed case is simple, so suspected cases with one of the following etiology evidence. So PCR of the virus is positive. All the viral gene sequencing is highly homogeneous to the new coronavirus, or a positive IgM or IgG antibody to the virus. So next, I will talk about the features of the patient presentation. So fever is the mostly observed symptom. So, but it is not only the indicator for the disease. So from this slide, we can observe that a large portion of patients on admission did not have fever. So all did not have high fever, moderate or high fever. So the fever is very low. So it is quite different from the cases of SARS. So that means this kind of patient is very easily to be negligible by the physicians. And here is the fever during hospitalization. So even for the hospitalization, so the patient, there is some, not very high, but some patients did not have fever. So even a severe patient, so 8%, over 8% of patients did not have fever. So do not be treated by fever. So no fever does not mean COVID-19 is not get. So here is some other presentations. The most besides a fever, cough is the most commonly observed symptoms. So, but other presentation should not be neglected. Nasal congestion, sore throat, this is the upper airway infection. So at the very beginning, so as only a few cases we have collected. So at that time we thought all the patients will have cough, but there is no patient with upper airway infection symptom. But at last, we realized that there should some patients have upper airway symptoms. And also some patients will have GI system involvement, like nausea, vomiting, or diarrhea. Although the percentage is not high, but there should be some. And shortness of breath are observed in about 20% of patients. It is correlated with the severe and critical care, critically ill patient ratio. So it is a very important phenomenon of the patient with severe disease. So here is a patient with COVID-19. This is the chest X-ray. So here is the X-ray in January the 2nd. So bilateral inflammation, ground glass opacity. So the left field is much heavier. So only 3 days later, almost all the lung field are infiltrated. So at this time, the patient presented a very severe situation. So here is the CT scan of COVID-19. So it is a common type of patients. So bilateral infiltration, mainly ground glass opacity, but in some portion the consolidation. There is no pleural effusion, no cavity. Here is another case with very severe COVID-19. The ground glass, certainly there should be some, but the dominant opacities are consolidation. Mostly is weight-dependent areas, very similar to ARDS we observed in other patients. And this is a mild case, so a very early disease, so only a patchy ground glass infiltration bilaterally. So this kind of patient, most of the patients like these do not have shortness of breath, but maybe some have some mild cough. So here is a new published paper on March the 9th. Here is the clinical cause of the major symptoms. So here is the fever. So maybe from on admission to the hospital, so it is maybe persistent for 12 days. Cough maybe longer for 2 weeks, over 2 weeks. And dyspnea at the very beginning, so there is now, but will appeared in about the second week of the disease. And here is the virus shedding. So as mentioned by Dr. Gao, so can be longer, as long as 20 days. So this is the non-survivor. So similar, but this patient is passed away. So they need ICU. So for about 12 days. So and in China, so we have 4 kinds of case stratifications. So mild case, common case, severe case, and critical ill cases. So the mild case, the patient will have some symptoms like fever or respiratory symptom, but there is no evidence of pneumonia. The common cases are showing fever and respiratory symptoms and with evidence of pneumonia. For severe cases, the patient will fulfill the following criteria. Respiratory is greater than 30 breaths per minute. Oxygen saturation is less than 93 at rest on room air. Oxygen pressure over fraction of inspired oxygen less than 300 millimeter of mercury. So for high altitude areas, so these parameters should be corrected by the atmospheric pressure. And if the patient have chest or CT scan, so the infiltration developed very quickly in 1 or 2 days. It is enlarged over 50%. So this is another criteria for the severe cases. Critically ill patients should be fulfill the following criteria: respiratory failure and requiring mechanical ventilation, shock, and the patient with other organ failure that requires ICU care. So diagnose the severe case is not very important because it is a little too late. So we recommend to early prediction of the severe cases. So some signs or symptoms may relate or parameters relates to the development of severe case. So for adult, the progressive decline of peripheral blood lymphocytes, the progressive elevation of inflammation biomarkers like C-reactive protein or interleukin-6. Lactic acid is also increased gradually. It is an indicator for the severe ARDS. Pulmonary infiltration enlarged significantly in a short term. So for children, the criteria is a little different. So tachypnea, dispirited or semblance, lactic acid is increased gradually. It is the same as adult. So bilateral or multi-lobe infiltration or rapid development. So it is very common for COVID-19, but most of the children are mild case. So bilateral or multi-lobe infiltration is seldom observed. Some infants less than 3 months with some comorbidities like congenital heart disease, bronchial pulmonary dysplasia, deformities of respiratory tract, abnormal hemoglobinemia, or severe malnutrition may be high risk factors for severe case. So, and also immunity deficiency or compromised immunity. Here is the patient or close contact management. So, Dr. Gao talked about some of them. I want to repeat some of the content. So, any suspected cases should be isolated and reported as soon as possible. It is very important. So, early detection, early reporting. So it is not just the duty of CDC, but it is a very important duty or responsibility of a clinician. So, clinician is at the front line of the COVID-19 war. So, when the clinician recognizes the first case and isolate the case, so this will may reduce or stop the transmission of the disease. And patient should be transported safely if they are needed. Certainly, if you have negative pressure ambulance, so it is recommended in China. But if you do not have, so maybe you can use other ambulance. But keep in mind, the driver should be protected very good, and also the window of the ambulance can be opened. So if the temperature is allowed. For close contact, all the contacts in China is quarantined in special settings or at home. At the very beginning in Wuhan, so some contacts are quarantined at home, but there is some problem because the family house is not good, not large enough, do not have the condition for isolation. So arose some cross infection at that time. So for determining if the patient can be quarantined at home, so you should look at the family house. If the condition is okay, so then maybe. But if the condition is not good, so it is better to send contacts to a special settings. And also in China, most of the city will test the virus in close contacts. This is very helpful to find symptomatic patients or to know whether the patient at an early stage or incubational period have ability for transmission. For suspected cases in China, they should be isolated and treated in single rooms, not in multi-person rooms. So this is for prevent maybe a suspected case is not COVID-19. If they live in a single room with other COVID-19 patients, maybe arose cross-infection. And also for suspected cases, the diagnosis can be excluded when 2 consecutive negative PCR of throat swab in 24 hours. Also, the problem for throat swab is that the sensitivity is low, so in some area. So perhaps due to the quality of throat swab, not the PCR itself. So, and also in some cities in China, so we recommend to test multiple samples, like the stool plus throat swab and the nasal swab, so that may be increase the sensitivity. Also, lower respiratory sample is very good. So, like sputum. So, for intubated patient, you can collect the bowel, the bronchial alveolar lavage. If a negative antibody test after 7 days since onset, the diagnosis should also be excluded. For confirmed case, they can be isolated and treated with with other confirmed patients in the same room. So for critically ill patients, they should be admitted to the ICU as soon as possible. This can reduce the mortality rate for these patients. So next, I will talk about the treatment of the patients. So, like many other patients, so support therapy is very important. Sufficient calorie intake for patients, keep water and the electrolyte balance, and also these patients should be closely monitored for vital signs of oxygen saturation. So COVID-19 is a little different from SARS. So for SARS, at the end of the first week, the patient will get the peak of the disease. But COVID-19 can persist for a longer time, maybe 10 days or 2 weeks, and the patient get worse. So if you neglect this change, so the patient can develop very quickly. Some examination could be repeated as needed. The blood routine test or urine routine test, depending on the demand. CRP or other inflammatory biomarkers can be repeated according to the progress of the disease. Biochemical analysis is a routine in China. So some patients should perform the coagulation function. ABG is indicated for patients with shortness of breath or any presentation of hypoxia. Chest X-ray or CT scan can be repeated as the patient situation demand. So for COVID-19, oxygen therapy is a very important therapy. So although it is supportive, but it can keep the patient comfortable and prevent the disease get worse. So you can use nasal cannula, oxygen mask, nasal high flow oxygen therapy, depending on the severity of hypoxia. So antiviral therapy are very important, but right now I have to say that there is no strong evidence to support the use of antiviral therapy. But in China, in Chinese guideline, we recommend this kind of treatment because there is some evidence either from SARS or from MERS or from viral studies. And recently, there is a little from clinical trial in COVID-19. After interferon nebulized twice daily can be used. Lopinavir, ritonavir is used more frequently in Wuhan. So right now there is a clinical trial come out. So although it is negative, but the study they select severe patients. So maybe the inclusion criteria, not the drug itself, let us not see the positive results. So I will talk it later in the next slides. Chloroquine phosphate has performed a clinical trial in Guangdong, but I didn't know the results yet. So, but Chinese colleagues told me that this drug can reduce the rate of severe cases. So we are waiting for the formal report. So maybe come out recently. Abidor is also another antiviral therapy, so recommended in China. So in vivo studies, this drug can inhibit the virus. So it is available in China for and indicated for anti-influenza treatment. It is effective. So right now, China recommend to use it for COVID-19 patient. I learned that there is a clinical trial for Abidor, but I haven't seen any formal report. So I would like to remind you that the safety and dosage of these drugs should be seriously considered in children, pregnant or breastfeeding women, or other special populations like liver disease or very severe renal disease. In China, a few cases accept a convalescent plasma treatment, so they most of them get very good improvement of the disease. So they are recommended to use for rapidly developed COVID-19. So not late. If you use to treat a very late case, it is no use. But if a mild case, it is no need. So just at the crossroad of a mild case to severe case, so that may be used. So here is the clinical trial of lopinavir, ritonavir, just published in New England Journal of Medicine. So the left part is the viral loading. So it seems almost the same. And the right one is the cumulative improvement rate. So it seems lopinavir, ritonavir is a little superior over control, but there is no statistical significance. I know some details about the study. So at the very beginning, lopinavir and ritonavir group enrolled at least 5 patients, but these 5 patients did not accept any treatment and they passed away. So this may influence the outcome of the disease of the study. So, and also the criteria of the study, they select a severe case. So that is not good for a viral disease. As you know, for influenza, you should initiate antiviral therapy as early as possible. So it should be early in the early 2 days, so the prognosis can be improved. So I think COVID-19 should be the same. So I hope that in the next clinical trial about antiviral therapy, so early patients should be selected, not late patients, not severe patients. So for life support is very important for severe and critically ill patients. So that is very similar to other severe pneumonias. Like others. So mechanical ventilation should be used. So in China, the first ventilation will be non-invasive ventilation. We will wait there, waiting for 1 to 2 hours. So if the patient can tolerate the ventilator and the patient condition improved, so non-invasive ventilation will be continued. But if the patient cannot tolerate the non-invasive ventilation, or the patient oxygenation gets worse, so we will transfer to invasive ventilation. Here I would like to remind you that non-invasive ventilation is much more complex than invasive ventilation. It is not a simple ventilation, although there is no need for intubation, but it needs the clinician to provide more close observation. So you should keep alert about the air leakage of the mask. If a large air leakage occurred, so the synchronization of the ventilator will be very poor, and the patient cannot tolerate. The other thing is that the pressure you provide to the patient. If at the very beginning, so you provide a very high pressure to the patient cannot tolerate it. So we recommend to first you give the patient a low pressure, then increase the pressure gradually, so the patient can get used to the high pressure. So and this can improve the toleration and also improve the effect of non-invasive ventilation. So invasive ventilation is similar to that of ARDS. So lung protective strategies should be emphasized, so to prevent ventilator-induced lung injury. A low tidal volume, 6 to 8 milliliter of kilogram ideal body weight. Low plateau air pressure, less than 30 centimeter of water. That is for the prevention of inflammation of the lung. That is for protection of further injury to the epithelial cells. And also appropriate PEEP should be used. So that is for prevent the collapse of the alveoli at the end of expiration, and this can reduce the shear force to the epithelial cells. Also reduce the lung injury. So for if the patient use in routine ventilation cannot acquire the good oxygenation, so prime position ventilation can be used. So we recommend to use at least 12 hours a day. So prime position is very good for ARDS. So it rotates the patient back up, and then the poorly ventilated area can have better ventilation. So it is a very good method to improve the oxygenation of ARDS, but it is more personnel resources. You should have enough number of nurses or interventionists. So when prone position ventilation or other open lung maneuver has no effect, so the patient can adopt ECMO. So ECMO in China, we used maybe over several hundred patients, but only a few has been survived. So, and the expenses for this kind of patient is huge. So we are curious about the poorly outcome. Perhaps we use ECMO too late. Too late, you cannot acquire any improvement, even for the highest technology. So right now in China, so we recommend to use it when oxygen pressure over oxygen fraction less than 8 millimeter of mercury, or the plateau pressure greater than 35 millimeter of mercury. So other therapies, first is the steroids. So I think steroids arouse a lot of arguments. So somebody said it is effective, somebody said no. So it may bring some side effects and can inhibit the immunity of the host. So from my own experience, either from the SARS or from COVID-19, there should be some patient responsive very, very good to steroids. So in Wuhan, we have a patient. So that patient intubated and accepted mechanical ventilation, and his physician gave steroids. So, and after 3 days, the patient extubated. It is the improvement is dramatic. So I think if you want to acquire a good response for steroids, so you should select the time. So when oxygenation or X-ray deteriorated rapidly, you'd better to become. You should better to use the steroids. Or if there is evidence of overactivation of systemic inflammation. So the dosage of steroids right now in China have some consensus. In the past, in the area, in the time of SARS, so some people use very, very large dosage. But right now, we have some consensus. So for methylprednisolone, 1 to 2 milligram per day, and the duration maybe 3 to 5 days, not maybe okay. So other therapies include circulation support or CRT. So it's lucky. So for COVID-19, we only observed a few cases with shock, a few cases with renal failure. So this is not a very popular therapies for COVID-19. Next, I would like to talk about the mortality. Now, mortality rate should be reduced. Here is the trends of mortality rate in China. At the very beginning, the mortality rate is high, but later the mortality rate is lower. Some special patients have a higher mortality rate. First, those accepted treatment in Wuhan. In Wuhan, the mortality rate is about 6%. And other areas in China is only 0.7%. So it is much lower. And also at an early stage, the mortality rate is very high. In Wuhan, about 70%, but less than 1% after the February the 1st. So that may first you should have good readiness and preparation. The second, you should have some experience handling such patients. Some other factors correlate to the fatality of the patients. First is the high age. So for age over 80, the fatality rate, the fatality rate is about over 20%. Males versus females is higher in China. I contribute to is not Chinese gentlemen have a much higher instance of cigarette smoking, and the female have a much lower instance of cigarette smoking. This is only one explanation. Other comorbidities may influence the mortality, like cardiovascular disease. The mortality rate is increased almost 10 times. Diabetes, 9.2%. For hypertension, 8.4%. Chronic respiratory disease, 8%. Cancer, about 8%. So much higher than not in control population. So when the patient accept treatment and the patient get better, the dischargement of the patient should be considered. So in China, we adopt the following criteria for discharging from the hospital. First, the body temperature return to normal for more than 3 days, and the respiratory symptoms is improved significantly. Pulmonary infiltration is stopped significantly, and also that is very important. 2 consecutive negative COVID-19 virus PCR of sterile swab in 24 hours apart. So also if the false negativity is increased in some area, so maybe you should combine the facial PCR or the upper swab or the sputum. So several kinds of sample do the PCR simultaneously. That may increase the sensitivity rate. So in China, there is some saying about the relapse of COVID-19. So some patient discharged from the hospital, and during the observation period, they accept the PCR again, and PCR is positive. So these are just some arguments about the criteria of COVID-19 dischargement. So here is a study published in a Journal of Infection Disease. So they collected 55 patients, and 5 have repositive or PCR after dischargement. So only 1 patient have fever. Other patients remain some respiratory symptoms. So the author said that it is a reactivation of the virus. So is it real? So for my own opinion, I think it is not a relapse of COVID-19. It may be the COVID-19 has not been cured. So the first 2 negative PCR was false negative. So that is either because the swab you get is not good, or the PCR technology has some problem. That is my own opinion. So maybe right, maybe wrong. So you can start yourself. That is my whole presentation. So I would like to share all of you to all of this content to you. So I hope that can bring some benefit to your prevention and control of COVID-19. Thank you very much.